Today we're going to talk about electrocardiograms correlation to cardiac events. So to measure the regularity and rate of heartbeats, we use an electrocardiogram or an ECG. The ECG can also convey if there has been damage to the heart, the size and position of the heart's chambers, and the effects of pacemakers or medications used to regulate the heart. The ECG device is used to detect and amplify the electrical changes caused by the heart muscle depolarizing during a heartbeat. The device can translate the information into a graphical presentation. So we want to look at what happens is it checks the regularity and rate of the heartbeats. It can convey if damage has occurred to the heart. It's used to detect and amplify the electrical changes in the heart, and it displays it. The ECG machine then displays it as a cardiac cycle, which consists of the P, Q, R, S, and T waves. Here's a picture of the P, Q, R, S, and T. The U is there, but it's not always visible, so it's not considered in this as often. So the cardiac cycle consists of normally a P wave, which is the atrial depolarization, a QRS complex, which is the ventricle depolarization, and a T wave, which is the ventricle repolarization. During a myocardial infarction, the ST complex, this right here, this represents the time when the ventricles are depolarized before repolarization begins. This is usually elevated. Atrial fibrillation is presented by a missing P wave with rapid, irregular, and not very efficient atrial contractions. When all normal waves are missing, ventricular fibrillation is occurring. What you see is rapid and irregular heartbeats that could quickly cause cardiac death unless electrical resuscitations, like an AED, are utilized immediately. This occurs with myocardial infarctions and heart failure. Ventricular fibrillation is thought to be caused when an action potential re-enters the atrioventricular node from the muscle tissue, triggering irregular, weak contractions that occur quickly and unsuccessfully pump the blood. So it's not moving the blood like it should, and the heart is not getting the blood it needs in order to process things the way it should. So here's an electrocardiogram device. A simple one. The ECG can also help your physician in diagnosing an unusually fast heart rate, which is tachycardia, or a slow heart rate, which is bradycardia. The ECG can provide information possibly on previous heart attacks by showing which areas of the heart may have been damaged or a current heart attack that is ongoing. If an ECG is done while presenting symptoms, it can help identify if there is reduced blood flow to the heart that could be causing the chest pains. The ECG can also provide information on enlarged hearts, heart defects, or other heart-related issues. So very important stuff. So symptoms that could call for an ECG. Your physician may recommend an ECG if you present any or a combination of the following symptoms. Chest pains are present, dizziness or lightheadedness, confusion, heart palpitations, rapid pulse, weakness or fatigue, or shortness of breath. Any combination of those, your physician may call for an ECG just to make sure that everything is functioning the way it should be. So looking at the study, they were looking at if exercising is the is the risk for an increasing frequency of silent myocardial ischemia, then we will monitor those exercising to try and make a difference. They want to see if we can maybe possibly find these people before something severe happens to them. So background information. Moderate exercise is healthy. The benefit of physical exercise exceeds the risk of sudden cardiac death. Participants are going to be ones that are involved in leisure sports. The participants are going to participants age 35 and over. So we as people consider moderate exercise to be healthy. Vigorous exercise may carry a transiently increased risk of sudden cardiac death. The sudden cardiac death rates that were sports-related and reported were approximately 1 in 100,000 subjects. When you move over the age of 35, it jumps to 1 in 10,000 for vigorous physical activity. The benefit of physical exercise exceeds the risk of sudden cardiac death. This study will try to determine if a preventative program of leisure time and competitive sportsmen between the ages of 35 and 80 can help with this statistic. So for the procedure, they're going to be gathering health information, performing initial ECGs, pre-screening through questionnaires, logging their activities. The participants are going to wear a cycle ergometer while they're doing their physical exercise, and then eventually they're going to get to a nuclear stress test. So health information that would be included for participants would be medical history, physical examination, and a 12-lead resting ECG. For middle-aged participants, the AHA, the American Heart Association, and the ACC do not recommend the ECG in pre-participation. In Europe, they encourage the use of ECG in pre-screening. Not sure why we have the difference, but we do. In short, the study will determine the value of screening sportsmen over the age of 35 that participate in leisurely exercise. Pre-screening looked for cardiovascular risk factors. These were obtained through questionnaires. Family histories, personal histories were also gathered and used. Physical activity for the study was logged as hours per week. Using the compendium of physical activity, the range is 0.9 sleeping to 18 metabolic equivalent of task. So that would be equivalent of running at 17 kilometers per hour. For the study, 4 groups of threshold values were used. One was 7.5 to 14.9, 2 was 15 to 29.9, 3 was 30 to 59.9, and 4 was greater than or equal to 60 metabolic equivalent of task hours per week. So the ECG exercise procedure, as I stated before, the participants wore cycle ergometers while they were exercising. They were in the upright position, exercising using progressive loading with stairs from 20 to 40 every 2 minutes until exhaustion. The increments used were adjusted accordingly by age and by usual physical activity to achieve maximum heart rate in 10 to 12 minutes, and also by gender. The maximal exercise was reached if the participants hit target heart rates. Male would be 220, female would be 210. And if lactate blood levels were greater than or equal to 8 millimoles per liter when measured within 2 and 5 minutes of recovery. Exercise-induced arrhythmias at the ventricular level had to be as frequent as greater than 10% of total QRS complexes or repetitive ventricular triplets or bursts if a complete left bundle branch block appeared, it was an intraventricular conduction. So the final element of this study after a positive exercise ECG was a second-line test using a nuclear stress test. So they're trying to make sure that if they identify somebody, they can go through, if they run the nuclear stress test, and seeing if they get the same results. So the population of the study was 1,500 middle-aged sportsmen, 1,205 of whom were men. And the chart here, it spells it all out: 1,500 middle-aged and leisure time sportsmen, 163 positive exercise ECGs, and it gives you the breakdown. The range in age was from 35 to 80 years. Asymptomatic sportsmen older than 35 had shown a 10.9% positive for ECGs for exercise. The main finding was attributed to the silent myocardial ischemia. 8.6% of the total population showed this result. This led to 23 coronary angiographies, 1.5% of the population, and 11 coronary revascularizations. The study shows that for every 100 sportsmen that are asymptomatic, ECG exercise tested, 1 could possibly be identified with a serious coronary artery disease that may need to be treated for prevention of a major cardiac event. So all in all, I would say that the study was a success, that even if they help 1 in every 100 when over the age of 35, 1 in every 10,000 are at risk, that would be a considerable value off that amount.